I want you to picture this. You're coming on to shift on a Sunday morning and you are praying that this is going to be a good shift because your last shift was chaos from start to finish. You walk in the door, start BSing a little bit, and then the pagers go off. 56-year-old guy that's down, cardiac arrest, CPR in progress. You arrive on scene, you hook up the monitor, and this is the rhythm you see. Would you shock that or would you not? I think it's worth a discussion. Let's talk about it. Welcome to Medic Outpost, where we bring emergency department thinking to the field and practical medicine to the medics who need it most. Because when you're the medic on scene, the emergency department begins with you. The content presented on Medic Outpost is for educational purposes only and is not intended to replace medical direction, clinical judgment, or local protocols. Always follow your agency guidelines and consult your medical director when making patient care decisions. I know what a lot of you out there are thinking, like, what the heck is Doc talking about? I can't shock asystole. ACLS says don't shock asystole. My medical director says don't shock asystole. But I'm not exactly talking about shocking asystole. I'm talking about shocking fine V-Fib that possibly looks like asystole on the monitor. Okay. Now, in ACLS, we're taught about different rhythms that are shockable and not shockable. And I'm strictly talking about pulseless ACLS here. Nothing with a pulse right now. We're talking, again, strictly pulseless rhythms here, okay? So there are shockable rhythms and not shockable rhythms, all right? The shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia, right? Now, the non-shockable rhythms are asystole and PEA, right? So, and the algorithm is clear in ACLS. Do not shock asystole. All right, so instead we perform high quality CPR. We concentrate on giving epinephrine. We're getting rhythm checks, right? Again, in the non-shockable rhythms. But there is a problem that we might be missing here. All right, not all asystole is true asystole. Sometimes that heart is actually in fine V-Fib, and the electrical activity in the heart is so small at that point sometimes that it's not picking it up on the monitor. When this happens, fine V-Fib can look exactly like a flat line, hence asystole. So why does this happen? Well, it happens for several reasons, okay? First, we have lead selection, all right? Oftentimes, the monitor just has one lead on at the time, right? So we have to switch leads or whatnot, right? Now, depending on that vector, fibrillation amplitude may be extremely small, all right? And then second, EKG gain settings, all right? If that amplitude setting is low, fine V-Fib can appear like asystole, all right? And third, we have monitoring, filtering, and artifact reduction, all right? So modern monitors filter that noise, but sometimes they also filter out very low amplitude rhythms, okay? So this can make fibrillating heart appear like it's flat, all right? So what does ultrasound show? All right, ultrasound studies recently, October 2025, in the Annals of Emergency Medicine, it shows that some hearts are actually fibrillating. About 5% of asystole patients show a fibrillating heart on ultrasound. So some of those patients are labeled asystole on EKG, but ultrasound actually shows a fibrillating heart. So, and you can actually see that fibrillating heart on echo. Now, in the emergency department, many physicians are just going to perform a subcostal view and check for that, okay? But that's kind of hard on the rig when you're not equipped with an ultrasound, all right? Now, why does this matter? Ventricular fibrillation is very treatable, all right? Overall survival of out-of-hospital cardiac arrest, overall, all comers, asystole, VTAC, V-Fib, PEA, all comers show about an 8% survival rate, all right? But with ventricular fibrillation and early defibrillation, it's about 20%, all right? That's a huge jump, okay? And for every minute defibrillation is delayed, survival drops about 7 to 10%, all right? So if a patient is actually in V-Fib and we call it asystole, we may miss that only treatment that may help, okay? So what can we do in EMS? All right, and by no means am I saying shock every asystole patient, because I know I will get a slew of angry emails, text messages, phone calls, whatever it may be, from medical directors or head of your agency saying, what the heck are you telling our medics to do, doc? All right, I'm not saying shock it, because ACLS says do not shock asystole. All right, but there are a few practical steps that we can take. First of all, carefully, very carefully confirm that rhythm. Now, I'm not saying stop CPR to confirm that rhythm. Of course, your partner or whoever is doing high quality CPR. The person not doing the CPR is confirming that rhythm very carefully. All right, if your monitor allows, change the leads, all right, or adjust the gain, all right. Now, granted, I know not all monitors are going to allow that, but if it does, and you can check it out if it does, but go ahead and check the gain and a different lead, all right. Continue high quality CPR, all right. That is a game changer, right? It has been shown day in and day out, high quality CPR is going to save lives, all right. And then again, good CPR definitely can increase that perfusion of the heart to actually allow that electrical activity of V-Fib to show up. And fourth, if you're one of those lucky squads that has an ultrasound on your rig, go ahead and do a subcostal view and look to see if they're by chance in V-Fib. All right, you can check to see if it's cardiac standstill, if there's an organized cardiac motion, or possible V-Fib. All right, now the controversial question, here it is. If the patient is in very early cardiac arrest and you're not completely convinced it's true asystole, should one shock be considered? Some experts argue that a single early shock may cause just very little harm, and if the patient would essentially survive otherwise, why not? Okay. However, that evidence is very limited. Okay. So I don't want you to go out and shock every asystole patient. All right. Because again, ACLS guidelines suggest against it. And again, if you're stopping CPR to shock asystole, you are giving up that ground you've already gained by doing good quality CPR. So, what's the final takeaway? Not every flat line is truly flat. Okay, fine ventricular fibrillation definitely exists, and it's proven to exist. And sometimes our monitors just simply can't see it. So when you see asystole, verify that rhythm, okay, and check multiple leads, adjust the gain, and again, please prioritize high quality CPR. All right. So in closing, if you by chance found this helpful, go ahead and hit that subscribe button and subscribe to Medic Outpost. And remember, knowledge over panic and skill over fear.